if you've ever dealt with that chronic dizziness, that just persistent feeling of being in motion, you know what I'm talking about. That frustrating, debilitating sense that you're just constantly off balance, it can completely take over your life.
It really can.
And here's the problem. When doctors try to figure out what's causing it, there are two conditions that get confused all the time, and that confusion can just completely derail a patient's journey to getting better. We're talking about persistent postural-perceptual dizziness, or PPPD, and vestibular migraine, which we'll call VM. Our deep dive today is built around a new 2025 narrative review that just meticulously compares these two disorders. Our mission is, well, pretty simple. We want to clarify the differences in symptoms, in their origins, and most importantly, how that changes how we treat them. So let's unpack this. Why is it so hard to tell these two apart, and why is getting the right label so critical for you, the patient?
It's absolutely critical, and it's difficult because these two conditions, they really represent the two major categories of chronic dizziness. The vestibular migraine, or VM, is famously the leading cause of episodic vertigo.
Right, the kind that comes and goes.
Exactly, that spinning dizziness that's unpredictable. But PPPD, that's now recognized as the most common cause of persistent daily dizziness. And they share so many features. Sensitivity to visual movement, that general feeling of unsteadiness means misdiagnosis is, frankly, extremely common.
And if you treat one like the other,
you guarantee long-term suffering. If we treat a neurochemical condition like VM, as if it's a learned functional one like PPPD, or vice versa, well, it just won't work.
That really sets the stage perfectly. So let's start with those core definitions, episodic versus persistent. What exactly makes a diagnosis PPPD? You mentioned it kind of unified some older ideas.
It did. PPPD is now classified as a chronic functional vestibular disorder. The Moreno Society, they finalized the criteria in 2017. And that really brought together these historical terms like psychosomatic dizziness or chronic subjective dizziness.
So what defines it now?
It's the persistence. It's a chronic sensation of non-spinning dizziness, unsteadiness, maybe a floating feeling, and it has to last for 3 months or more on most days.
So chronicity is the big flag. This isn't just a bad day, it's a constant state.
Exactly. And the symptoms are predictably worsened by 3 specific types of triggers.
Okay.
First, just being in an upright posture. So simply standing or sitting up.
Just fighting gravity.
Right. Second, active or passive motion. That could be you walking or even just being a passenger in a car.
Okay. And the third?
And this is a major clue exposure to complex visual stimuli.
Ah, visual vertigo.
Yes. Navigating busy store aisles, watching an action movie, even just scrolling on your phone.
So if you're trying to walk down the cereal aisle and all the bright colors and patterns just feel overwhelming and they make you feel unstable, that's PPPD.
That's a perfect illustration of it. That constant daily struggle with predictable triggers. Now compare that to vestibular migraine, which by definition is episodic.
So it comes in attacks.
Exactly. For a definite diagnosis, you need to have at least 5 episodes of vestibular symptoms. That could be spinning vertigo, non-spinning, visual vertigo. And they last anywhere from 5 minutes up to 3 full days, 72 hours.
Wow, that's a wide window. But the core idea is that there are clear episodes, not just a constant daily baseline of dizziness.
Precisely. There are symptom-free intervals, and critically, these episodes have to be tied to a history of migraine.
Ah, there's the link.
Right, and at least half of the attacks have to include classical migraine features.
Like the headache itself, or...
A migrainous headache, yes, or a photophobia, that extreme sensitivity to light, phonophobia, sound sensitivity, or even a visual aura. Those features point us directly toward the underlying migraine biology.
Okay, but this is where it starts to get muddy, right?
Yeah.
Because the review notes that up to 55% of all migraine patients report some kind of vestibular symptom. And VM itself is the trigger for PPPD in something like 15 to 20% of cases.
It is.
So if a VM episode can kick off PPPD, is PPPD just what happens when the brain gets stuck after an attack and never fully recovers?
That is the ultimate question.
Yeah.
And the way we answer it is by looking at their origins. This is really the core distinction. A neurological process versus a learned functional one. Let's start with VM. Its origins are tied directly to the general pathophysiology of migraine.
Okay.
So we're talking about a state of cortical hyperexcitability.
Wait, cortical hyperexcitability? That sounds incredibly technical. Can you give us a simple version? Does that just mean the brain is running too hot?
That's a great way to put it, actually. Think of the brain's sensory processing centers as having an internal smoke detector.
Okay.
In someone without migraine, that detector is calibrated perfectly. But in a patient with VM, That detector is way too sensitive. It's constantly firing off alarms, the dizziness, the light sensitivity, even for a really small stimulus.
And what's causing that oversensitivity?
It's a chemical process. That running hot is mediated by chemicals, most notably one called CGRP, calcitonin gene-related peptide. We have evidence showing that the vestibular nucleus, the brain's balance center, has receptors for CGRP.
So during a migraine attack, that chemical activates the balance center directly.
Exactly. The dizziness stems from that direct chemical activation. It is fundamentally an organic neurochemical disorder.
Okay, that clarifies the nature of VM. Now contrast that with PPPD. That sounds much more like a feedback loop, something psychological or behavioral.
It is. It's considered a functional or learned disorder. PPPD arises from what we call maladaptive changes in how the brain organizes postural control and integrates all its sensory information.
So it's not a hardware problem, not a lesion.
No, not at all. It's a persistent, incorrect strategy the brain has adopted. Modern models, they call them third-generation models, they explain this really well. After some kind of initial trigger, which, like you said, could be a bad vertigo attack from VM, or even just severe psychological stress, the brain shifts gears. It goes into what's called a high-stakes postural control strategy.
High-stakes strategy. What does that look like in practice?
It means the brain becomes hypervigilant. It dedicates way too much energy to ensuring stability. It prioritizes this rigid, fixed balance strategy just to prevent falls.
And how does vision play into that?
That's the crucial part. It starts to over-rely on vision for its balance cues, and it starts to neglect the information coming from the inner ear and the body's position sensors.
So that's why the grocery store aisle is a problem. The brain is trying too hard to use visual data to stay stable.
Precisely. And that over-reliance is what paradoxically creates the feeling of instability.
That's fascinating. So VM is organic hyperexcitability, but PPTD is this chronic functional maladaptation. The brain learned a bad habit and got stuck. But I have to ask, for the listener who's maybe been told their dizziness is psychosomatic or all in their head, how hard is it to really separate a learned behavior from a subtle underlying organic cause? Aren't we at risk of just applying old stigma to new definitions?
That's a crucial question, and it's why the field is moving so carefully. Neuroimaging studies are actually helping us see the difference, though.
How so?
In VM, during an attack, you can see evidence of increased activity. That's the hyperexcitability. In PPPD, imaging tends to show the opposite. Decreased vestibular cortical activity and altered connectivity in those visuovestibular networks.
So it's not hyperactivity, it's misdirected activity.
It's evidence of that persistent, inefficient shift in how the brain is processing balance. Less about being too hot and more about using the wrong strategy.
This distinction is so critical because if the brain can make migraine episodic headaches become daily chronic headaches, it seems logical that episodic vestibular problems could become persistent too. And that leads us right into this whole debate about chronic vestibular migraine.
Exactly. We know chronic migraine exists 15 or more headache days a month. So classifying VM as purely episodic seems, well, too simplistic. It's highly plausible that a chronic or persistent form of VM exists, and it would be driven by the same neurobiology that drives chronic migraine, especially something called central sensitization.
Central sensitization. What does that mean in practical terms for dizziness?
It means the entire central nervous system gets stuck on high alert. It's a persistent, amplified response to stimuli. A key marker for this is allodynia.
Where something that shouldn't be painful is, like brushing your hair.
Exactly. And the review notes that up to 68% of VM patients report cranial allodynia during their attacks.
That's a staggering number. So if the nervous system becomes that sensitized, the dizziness could just linger.
Right. If that sensitization persists long after the acute VM attack is over, it could show up as chronic daily dizziness that looks almost identical to PPPD. The patient feels dizzy every day, but the cause isn't just a learned behavior. It's a persistent underlying neurological hyperstimulation.
Which creates a huge diagnostic dilemma.
A major one. Should clinicians just call everything PPPD if it lasts 3 months? Or do we need to recognize chronic VM as its own thing? The danger is real. If we misclassify a chronic VM as PPPD, we risk psychologically harming the patient, by calling their problem functional, and we delay the medical treatment they actually need.
So it comes down to really deep history-taking.
Meticulous history-taking, deep phenotyping, to find those subtle clues that point back to migraine biology.
Okay, let's pivot to the practical side. Treatment. Because if the causes are so different, the treatments have to be radically different. This is where patients need the most clarity. But here's the tension I see. If one condition is treated with physical movement and the other is defined by a sensitivity to movement, what happens when they overlap? Let's talk about that VRT conflict.
That conflict is the daily challenge in the clinic. For PPPD, because it's that functional maladaptation, the goal is to retrain the brain. You want to reverse that high-stakes strategy.
How do you do that?
The cornerstone of PPPD treatment is vestibular rehabilitation therapy, or VRT.
Right.
This involves targeted, controlled exposure to motion and visual stimuli. You're gradually desensitizing the patient's hypervigilant system, and the results are good. Studies show a 60 to 80% symptom reduction over a few months.
And it's not just physical therapy, right? There's a psychological component.
Absolutely. VRT is almost always supported by cognitive behavioral therapy, CBT, and often serotonergic meds like SSRIs or SNRIs. The goal is to manage the anxiety and break those maladaptive behavioral loops. It's a cognitive physical therapy approach.
So for PPPD, you're almost forcing the brain to unlearn its bad habits through movement. Now, contrast that with VM, which starts as a neurological problem.
For VM, treatment is primarily medication-focused. You're trying to calm that hyperexcitable cortex. It responds to traditional migraine preventatives. The review highlights strong evidence for drugs like flunarizine as an effective preventative for VM.
What else is used?
Propranolol, venlafaxine, which is interesting because venlafaxine can work for both VM and PPPD, likely because it helps with both migraine prevention and anxiety.
But the really exciting stuff is the newer targeted treatments.
Yes, the CGRP-targeted therapies. The recent investment study was a placebo-controlled trial, used a CGRP monoclonal antibody called galcanezumab, and it found that it significantly reduced what they call definite dizzy days.
And it also helped with something called the DHI.
Yes, the Dizziness Handicap Inventory.
Let's pause there for a second. The DHI, what does that measure, and why is reducing that score so important?
The DHI is a crucial patient-reported outcome. It asks how dizziness is impacting your emotional, functional, and physical life. Seeing a significant drop in that score means the drug isn't just stopping the dizzy spells, it's dramatically improving the patient's actual quality of life.
So it's proof that targeting that core migraine chemical, CGRP, directly treats the vestibular symptoms.
It's very strong evidence, yes.
Which brings us right back to the conflict. If VRT, the core treatment for PPPD, requires you to engage in movement, but VM patients are defined by their sensitivity to movement, wouldn't starting VRT on a patient with an underlying VM just make them worse?
It absolutely can. And this is the clinical tightrope we have to walk. If a patient is highly movement sensitive because of an active migraine process, VRT might just overload their system and make the chronic symptoms even worse.
So what's the solution?
The review strongly suggests that in patients who look like they have PPPD but also have clear migraine features, you have to treat the migraine first.
Prioritize the neurobiology.
Exactly. Use migraine preventatives to calm the central nervous system down first. If you can do that, you might dramatically improve how effective VRT can be. Then the patient can finally break that cycle of maladaptation.
That provides a really clear path forward for patients who have been stuck. The takeaway is that this requires deep phenotyping to get the right label on the right problem to find the right treatment.
Absolutely. To sum it up, PPPD is defined by its persistence, its predictable triggers, and it's best treated with VRT, CBT, and medications to retrain the brain.
In VM?
VM is episodic, marked by those classic migraine features, and you treat it primarily with migraine preventives, including now these targeted CGRP inhibitors.
The bottom line seems to be screen every single patient with dizziness for migraine symptoms.
You have to.
The review really shows that this diagnostic problem comes down to a fundamental tension. The brain can learn to be dizzy, but that learning process often gets kicked off by an organic neurobiological change that then gets stuck.
That's precisely right. So if a patient presents with chronic dizziness that feels behavioral, but they have a clear migraine history, you have to target that underlying biology to allow them to heal functionally.
It's the only way to break the cycle.
It is. And that leaves us with the provocative question for you, the listener, as this field moves forward. How much of what we currently classify as functional dizziness is actually the long-term structural result of persistent, unmanaged neurobiological hyperexcitability, demanding a medical, not just a physical intervention? That's the challenge clinicians are facing every single day.